All right. Well, we got another great case with featuring some shockwave technology with Dr. Arvin Narula, the Amazon Prime of interventional cardiology across the San Diego County. So, Arvin, what's up, brother? Let's see a cool PVD case.
Here we have a peripheral vascular case. We're now interventional cardiovascular disease specialists here. So here's a case presentation. 67-year-old man presents with right lower extremity non-healing wound on the first three digits. The patient has a history of diabetes type 2, peripheral vascular disease, hyperlipidemia, and hypertension. So if you look at this case, this patient had CFA disease and then distal SFA disease with heavy calcium, and there's really poor runoff. Unnamed vessels below the knee, kind of recannulizes into a perineal, which is kind of feeding the foot, and then can't really name any other vessels after that. So this case is a tricky one, not uncommon in patients who have wounds on their legs. Again, there's really poor flow to the foot. So this is one of these scenarios where you always get concerned that you're going to need some kind of calcium modification strategy, especially in that distal SFA. But with runoff like this, I really get worried about using atherectomy in these scenarios. So,
Yeah. Well,
thankfully,
there's no worse scenario than having a great result on the SFA and then you've got no reflow to the foot and you're giving verapamil or adenosine or whatever.
And usually the patient is in a lot of pain because there's a lot of no reflow to that area, and it's just not a great scenario. Yeah. So again, thankfully, Shockwave came with the M5 and M5 Plus. The M5 is the original peripheral vascular technology. It has a 110 centimeter shaft. It's 6 millimeter balloon is compatible up to 6 French. The 7 millimeter the M5 is compatible to a 7 French, and it's 30 pulses in 30 seconds. Thankfully, the M5 Plus came along, longer shaft, so you could do kind of R2P cases if necessary. And these balloons actually go as low as 3.5 and then up to 7 millimeters, and these are all 6 French compatible. So I've actually been using this 3.5 millimeter balloon kind of below the knee to modify calcium in that scenario. And again, it's not like I'm going up 1-to-1, up to nominal pressure. I'm kind of going 1-2 atmospheres if I think it's way bigger than a 2.5 or 3.0 vessel if necessary. But the other nice thing about this is, again, 8 millimeters is 8 millimeter balloon is compatible up to 7 French, and this is the best part. The 30 pulses in 15 seconds really speeds up your case time, and I feel like once you start using this, it's really hard to go back to the standard M5.
So, Arvin, can you do BTK cases radially with this, or is it
no? From a 135 shaft below the knee would be really tough.
So you basically reach the SFA with this, possibly, but
yeah, SFA is feasible, but below the knee is tough. And again, you can go up and over from the contralateral groins to the other side to do below the knee, but it's tough to reach from the wrist. Mm-hmm. So the next thing I just wanted to kind of highlight is this the L6 balloon came along. The L6 balloon now is kind of designed mostly for the iliacs. A lot of these folks that are needing calcium modification before TAVR or MCS, these balloons are a little larger. The 8 and 9 millimeter balloons fit in a 7 French, and the 10 and 12 millimeter balloons fit in an 8 French, and it goes over an 018 guide wire. The catheter working length is a little shorter than the M5 Plus, and again, it's a little slower right now, but the energy profile is different. If you look at the M5 Plus, the emitters kind of emit the most amount of energy, but this is kind of pretty consistent throughout. The pulses are pretty consistent throughout the balloon, which is kind of nice. So you kind of don't need to use those emitters as much and line things up right exactly where those calcium nodules are. So here's our case. Going back to our case again, we knew we were going to have a calcium modification. We knew we were going to need a calcium modification strategy. If you look here, I kind of had this set up right in between the emitters. But the nice thing is you can kind of move these pulses around here and there, and it looks like there's some underexpanded portions of this balloon, which is nice. So you just line up those emitters kind of where your ruler is and where that calcium is, and you can kind of get a nice result after you kind of fracture that. So here's another example of that, where again you'll really see that there's a good bit of calcium there. It's again right in between my emitters, but you can pull these back slowly. And again, that's where the 30 pulses in 15 seconds really helps kind of decrease your case time, because I'm kind of dragging this all along a pretty large location. Um,
And
Again,
again,
this
Marvin, you're not using distal protection for this, right?
no distal protection for this. Yeah, that's the other nice part. Um, you know, it just saves a step from that, where you don't need to use a distal protection device. And again, I've not really had many issues with no reflow using these balloons at all. So again, here kind of shows nicely that the Shockwave balloon is actually well expanded. It looks like we've modified our calcium enough. Then the next step, what I do is I take just a regular balloon before a DCB, and then at the end I'll use the DCB and kind of deliver drug therapy to that area. So again, really nice balloon expansion with this. I think Shockwave has really become a disruptive technology in the peripheral space, because again, those issues with no reflow have kind of pretty much gone away with this. So it's really nice to have this on the shelf.
Yeah,
Here's
that's
the
great.
result.
Wow.
Really nice expansion. Again, heavy calcium. You saw that, and again, all those issues and discussion of no reflow with unnamed vessels. I mean, this looks like it's way better result than when we had originally. And again, all unnamed vessels until, like, you kind of see a perineal rolling in, and then you do get some more blood flow to the foot. And again, hopefully this is enough for wound healing for this patient. So again, I think in terms of calcium modification strategies that we have, we have orbital on the shelf, rotational on the shelf, and directional on the shelf. Orbital's nice. It's definitely been there. We use it quite frequently. But again, those cases where there's one vessel runoff or unnamed blood vessels below the knee, I always get concerned about using them. Rotational, I don't really have on the shelf. I know a lot of other folks use rotational atherectomy in the peripheral space, but I don't really have that, and I'm not too familiar with it. Directional is nice. Directional can be used in for calcium modification, but I feel like it takes a little bit extra skill set, way more skill set required than IVL,
Yeah,
especially in the leg. I mean, it can kind of just bounce off, and you need to kind of really have that device, and probably need a good amount of experience with it. But I mean, in terms of ease of use, safety, and no worry about no reflow, it seems to be a great option in these cases.
that's great. Marvin, can you take us through your workflow for kind of wound healing with this patient? Do you have a clinic that they'll see, or what's your follow up going to be for
Yeah.
them to see?
So the way our workflow works is, again, we work in a few different hospitals. It depends if hopefully the patient can see us in the office. Depends on the insurance, but if this patient is able to see us in the office, we'll usually see the patient in the next week or two. We have an office visit. We have our vascular team in our office, and we'll kind of take a look at wound healing, and we also are involved in. We have a wound clinic through the hospital that we refer our patients to. So in these types of cases, we usually like to kind of follow these patients progressively throughout time. In our office, we like to make sure that they're on the appropriate medical therapy. And then the second part of it is in terms of wound healing, we'll check on them. If their wounds are not healing, we revisit and relook at the angiogram. Are there any potential targets that we could do, right? So for example, in this case, if this patient doesn't see benefit from what we did, is it worth it to maybe go after the perineal and see if we can kind of improve flow that way?
I love
So
it. And where do you get these patients from, Marvin? For interventionalists looking to do more peripheral work, where are you getting referrals for these patients? What have you found to be successful outreach strategies? Are you
yeah.
bringing them to the podiatrist's office? Are you
Mhm.
giving them brown bags of cash? What have you found is successful?
So I think for us, just one is being available, like everyone kind of teaches you, and then telling your hospitalists and podiatrists that you have an interest in it, because more frequent than not, people are looking for people to do this work. The podiatrists and the hospitalists are looking to do this work. So if you live in the proper area, if there's a lot of diabetes or end stage renal disease around, just let folks know that you're interested in this, and you'll start getting phone calls. And then, I mean, once these folks start seeing results, because again, we know the data, many of these folks go through life with getting an amputation and not an angiogram. And
Yeah.
that's really sad that again, a lot of the patients where you could potentially make a big difference in someone's life, a lot of them aren't even being treated. So, I think, befriending a podiatrist, befriending a hospitalist, and letting them know that you're really interested and you have a passion about this, that has really increased our case volume quite a bit.
Yeah. We had a guy, the busiest OBL in Boise is a vascular surgeon who went around to every podiatry clinic and got them to invest in the OBL. So all the podiatrists have an investment in this OBL where they send their patients to, and they get basically a legal form of kickback from their investment in the OBL because they get like dividends and pass-through income.
I wonder if that's different in different states. I'll have to ask our artificial intelligence, my lawyer, on that. I'd be curious to know what the if there's state by state difference in that.
Yeah, no, that'd be interesting. Well, dude, Amazon Prime, always ready for a new order. I appreciate it, buddy. That's a great case. Thank you.
Within 24 hours. Thanks.